to do a bronchoalveolar lavage, which is drop the camera down the trachea, go into the bronchus, squirt some sterile saline, aspirate it, and you will get your bags in a clean way. Now, because of how invasive it is, it will only be done if necessary on rest wards in ICUs, but not in your typical AGM day. Now, if you have bone and joint infections, you will want your sterile surgical samples. So surgeon will go in under sterile field and get samples from deep tissue, trying to get which should be sterile. They will typically get 5 samples, and if there is something in more than in 3 or more of them, you can consider that something is probably there. Uh, Now, sometimes people do kind of surface swabs of those infections, which are pointless because they will just give non-specific growth. Kind of the middle ground, which is still useful, is the tissue samples collected by podiatrists, for example, for diabetic foot infections. Those can be useful, and those we can semi-reliably use, knowing there may be still some non-specific growth. And finally, you have your cerebrospinal fluid, which will be covered for sure in your neurology revision. And this is what you will do when you want to test for meningitis or encephalitis. So, start smart, then focus. The questions you have to answer is, first of all, is there an infection at all? Is there a clinical syndrome that could be infection? The key thing that they will quiz you on is if there is no infection, in that there is no dysfunction, there are only a few cases where you will treat asymptomatic presence of bacteria or viruses. If you have symptoms, you have location, and you have your history, you will deduce your most likely pathogen before you get any lab results. Now, given that, you can think what samples and what tests are useful. And useful is important question, as in which ones will change the management. Doing tests just for the sake of confirmation, something we are 100% certain, is not a good use of NHS resources. Now that we have that, you're even before we get the results from that, as those will typically take a few days, if you are thinking bacterial, you will do empiric antibiotics. And that's why knowing the most likely pathogen is important, as you will be able to do targeted broad spectrum antibiotics. You will know that you're for community acquired pneumonia, you will go with amoxicillin. For your GI tract infections, you will go with, or abdominal infections, you will go with Coamox or ceftriaxone and metronidazole. But you need to know what you are looking for and what is your likely pathogen. We will cover a little bit of that in a second. Important thing, and I am only putting point number 5 after point number 4, as it's easy to give empiric antibiotics, and that's what you will do first, usually. But in an ideal world, in most cases, you will start with source control. If the infection is due to a huge stonking abscess in their thigh, you will drain that abscess. If they have an infected line that is going just above their heart, you might want to pull that line out. If they have an infected pacemaker lead, ideally you would remove that. It's not always possible, but LabMed questions will want you to consider, is there a possibility of source control? As that will be more important, and that's the thing that will actually enable you to cure the infection. If there is an infected locus, your antibiotics are only going to put a It's as if trying to stop a crumbling dam with a band-aid. And finally, you will finally get your blood culture results, and then you will be able to rationalize antibiotics. For example, you are doing your abdo infection, you've started with Coamox, as you should have, but your results come in, and it shows up that this E. coli is sensitive to just amoxicillin. The correct LabMed answer will then be switch antibiotic to amoxicillin. You want to go as narrow as you can in that then focus stage. Or ideally, if there is no bacteria or nothing that you can treat, you will just stop. No point giving antibiotics if there is nothing to treat. Now, this is a summary slide that I have shamelessly stolen from the lectures. I don't know whether you've seen or whether the new micro lecturer has changed it, but it's a nice summary and we'll receive it. You have it on your LabMed lectures probably, and I will send it as well, as to what is most common. And kind of the rule of thumb is if it's above the diaphragm, it's most likely gram positive. The exceptions are maybe not full exception, as strep pneumo is still most common for meningitis, but you have significant gram negative presence. You have to remember that your skin and bone are above the diaphragm in this case, and everything that is only present below the diaphragm, so your GI tract, urinary tract, and your diabetic foot, will be primarily gram negatives. Anybody wants me to elaborate on any particular bugs? No worries, you can always let me know a bit later. And now we have the Socrative number one, unless people have already answered it. So we have 3 students currently on board. Is there anybody else that wants to join to the Socrative? Just let me know. And once you have joined, please answer the first question. I will wait for like a minute or two. And given experience from the previous Socratives, I will then reveal the answers and we will discuss. Don't be afraid of giving me the wrong answer, because I will discuss why the wrong answers are wrong as well. Okay, let's have a look. Okay, that's actually a really good spread. Uh, so, in terms of the questions, we have a nurse reviewing a patient. There was an ulcer on patient's leg, and there was a result from the wound swab. Coagula is positive cocci in clumps. Sensitivity is pending. So we know that we have our coagulase positive cocci, which, as you will know, are most likely staphylococci, but we don't know what they are sensitive to. Now, the wound look granular or red with minimal surrounding erythema. Now, what this question is getting at is that the wound, when they heal, they become granular. If they are red, it's fine because they means that they are nice and well perfused. And surrounding erythema is minimal, as with a healing wound, you will expect some inflammation, but it shouldn't be overwhelming. So this, and of note, patient has no symptoms and no problems. Therefore, if you think about it, it's actually a ulcer on a patient's leg that's healing just fine. Therefore, the correct answer is, as some people have chosen, 50%, to reassure and discharge, as this patient does not have an infection syndrome. And if you think about it, this ulcer is on the skin, and oftentimes the wounds on the skin will get colonized by bacteria that live on the skin. And that will include things like staphylococci. As for why the other answers are wrong, collection of surgical samples is a nice idea if we are thinking about a tissue infection, though it will typically be more related to things like deep tissue infection. It's not a bad idea for an ulcer, especially if we think it's going deep and there is something bad going on. But this one is unlikely to be infected, so there is no need for that. However, it would be a very good answer if there was infection syndrome. So if the wound was draining pus, it was not healing, it was looking a weird color. But good thinking, but you have to remember about the first question of our diagnosis pathway. Is there actually an infection syndrome? Giving oral coamoxiclav is also a nice idea. You have identified that this is likely a staph, and indeed, coamoxiclav would be a good treatment for staphylococcal infection. However, similar to the first part, is our patient does not have an infection syndrome, so actually, there isn't anything to treat. Okay, so that was a nice warm-up, and here we go to the commensal infections. So kind of similar to our skin infections, we are thinking essentially we are covered in bacteria, whether we like it or not. Unless somebody wants to do daily showers in chlorhexidine, they are not going to be sterile. Uh, Now, as I've said, if the patient is well and there is no infection syndrome, your positive cultures will most likely represent contamination. So, for example, repalpating a vein after you have before taking a blood culture, or colonization, such as in our wound swab, which is a surface swab, just from the surrounding skin. Now, if the patient is unwell and you grow something that is atypically commensal, such as staph epidermidis, you want to repeat cultures. It's just because it is likely that it is just a contamination or colonization, and you don't want to overtreat, so you would typically repeat the sterile culture, in particular blood culture. If there is two positive culture results and the patient is unwell, then you would treat. Of note, when you have line infections, such as you may go to the gastro ward and you will always see several patients with Crohn's disease who are relying on parenteral nutrition or IV nutrition pretty much. They have lines, and essentially they are passing high glucose solution through those lines every day. It's not surprising that those lines get infected, and there will always be at least a few of them on the ward. If you are suspecting a line infection and you grow staph epidermidis, which indeed is the most common things you will grow in those patients, you want to do paired cultures. So you want to grow the line and you want to grow peripheral vein. If you grow just the line and if you grow just the line and nothing on periphery, you want to repeat. If you then grow nothing, you probably just contaminated initial line culture, for example, by not wiping the port with your chlorhexidine wipe. If the reverse is opposite, in that peripheral culture was with staph epidermidis, you have likely just contaminated the initial peripheral culture, for example, by repalpating the vein. Now, if you get repeat growth from the line, it means that the line is likely colonized, but the infection hasn't spread to the patient. This is a state when you are a little bit more curious or careful, but if the patient is well, you can actually leave it like that until things get worse. As inserting a central line is not a fun thing to do, and it's oftentimes quite difficult. Now, this is the when shit hits the fan, which is you grow stuff from both, and you again grow stuff from both. This is your diagnosis of line-associated bloodstream infection. Your patient is likely unwell, they are getting admitted, and you treat them for bloodstream infection. Again, this is a summary of how to diagnose different things in terms of investigations. I'm not going to go through everything, but you want to ask yourself, what's the most likely thing? And once you know that, you want to ask, is it culturable? Will it grow? If so, culture it, and then you can do a lot of different things. If it doesn't grow, or it's something, you know, that is not visible on microscope, you can do different tests, such as trying to detect immune response, such as antibodies, cellular response, or you can detect the presence of antigen, which is essentially a characteristic molecule on your pathogen, with things such as ELISA, lateral flow tests, or your PCR. Finally, you can things which can be seen by microscopy, which will be large things, your bacteria, your cryptococci or other fungi, TB, parasites like malaria or giardia. Now, this is a summary of the most common stains, as you may have some stain examples on your exams. Indeed, this is a picture from our LabMed exam. So let's just go through the characteristic things. Now, the gram stain will be one of combination of one of those two. And as for gram positives, sometimes people find it difficult to differentiate what is gram positive and gram negative. They say positive is purple, negative is pink, and if you ask me, they both look a bit purple. However, if you are thinking about gram positives, you will get good quality stains, and gram positives are very dark purple, essentially getting towards black in some areas, whereas gram negatives are towards the pink are very light purple. I hope that's a bit more helpful than the explanation that is commonly used. In terms of morphologies, you have things which looks like rods, which are bacilli, and you have 2L in bacilli, and this is what you are looking for. And in cocci, most of the letters are round. And what you are looking for? You are looking for things which looks like little balls. Now, if you think about it, then you can think about what do they look like? In here, they are in those nice chains, so these are most likely streptococci. They can also be arranged in like those big clumps, which is where you would think about staphylococci, and that's your gram stain analysis done. If you look this stain with kind of those bacilli that are on this sort of weird bluish background, that's your Thiel-Nielsen stain, and that's almost always means, at least for your case, exam case, TB and mycobacteria. Mycobacteria in general, but usually TB. In terms of the other stains, you have your India ink stain with those characteristic halos, and this is specific to cryptococci. And finally, you have Giemsa stain. You will see those red blood cells with those tiny little circles or different things floating inside the red blood cells. And those will indicate parasites. In your case, the most common things they will inquire about is malaria. So again, pros and cons of the key methods. Culture. Oftentimes the question wants a gold standard or sensitivities for bacteria. So the culture gives you sensitivities, and for many bacterial infections is a gold standard. The problem is it only detects live bacteria. So if you are looking for viruses, go back. Uh, Better luck next time. Antibiotics. After antibiotics, you're not going to find a lot. And it always takes a few days to come back. If you are trying to culture TB, you might as well go on a quick vacation as it will take a few weeks. If you are thinking about PCR, this is when your question wants viruses or the fast diagnostic. So it is fast. The result ideally takes a few hours. It will detect all kinds of pathogens, so bacteria, viruses, parasites. Pretty much if it has genetic material, it will detect it. Which I think the only exception to that is prions, which we don't cover in LabMed. The problems with that is it has reduced sensitivity in some cases. We will cover the herpes simplex virus. As well, it's more expensive, in particular if you are talking about panels. Finally, you may get a question about MALDI-TOF. It gives you detailed identification of bacteria. Oftentimes you will get sensitivities and other things about them. But the key thing is takes time because you need the culture first. And here are the treatments. The key treatments you need to know are antibiotics. We will cover a few things about antibiotics, but here are some kind of nuggets of wisdom. You remember the community-acquired pneumonia, but for your hospital-acquired pneumonia, you want to use Coamox. Why? Because you are thinking about resistant gram-negatives. Your resistant E. coli is likely what's now hopping around your patient who you have been ventilating for the past week. If you give your patient too much Coamox, now you have problem because they have ridiculous diarrhea, and that's your C. diff that has decided that this looks like a nice real estate. This one you treat with the oral vancomycin. It is one of the few gram-positives in the gut. As we've discussed, the gut is primarily gram-negative. Vancomycin only treats gram-positive, so it actually nicely targets C. diff while leaving other things behind. For your abdo infections, you do either Coamox or cephalosporin with Metro. And why you do that? That's because you need to cover anaerobes, your bacteria which do not use oxygen. Now, Coamox covers anaerobes, cephalosporins do not. That's why you need to add metronidazole. In your patients, sometimes you will get a question about patient with a rash after penicillins. If they just have something mild, you will typically use other antibiotics than penicillins in that case. But if they are septic with something resistant and their only option is, beta lactams or a bad day, or you could also call it a significant emotional event, you would consider carbapenems as they are highly effective and there is only 1% risk of cross-reactivity. Now we need to know three main mechanisms of resistances. You have your methicillin-resistant Staph aureus, which decides to alter its penicillin binding protein 2A or PBP2A, and it gives it resistance to almost all beta-lactams apart from vancomycin. Vancomycin is not a beta-lactam, but it works in a similar site. But it gives it resistance to beta-lactams and cephalosporins. You have your ESBLs, which is essentially extended spectrum beta-lactamase or beta-lactamase on steroids. It allows it resistance to penicillins, plus minus beta-lactamase inhibitors. Uh, so means that you cannot use your ceftriaxone anymore. However, these things are still not able to cut the carbapenems, which is why CPE are scary, which is the carbapenemase producing Enterobacterales. And as the name suggests, carbapenemases cut everything. They cut penicillins, they cut cephalosporins, they cut carbapenems as well. Therefore, it means that you need to think about something else. And there is not much anything else that has as nice a side effect profiles as those antibiotics. Again, the lovely summary of the key antibiotics. Uh, so, if you are thinking simple strep, your penicillins are fine. If you have things such as E. coli, which oftentimes will have simple beta-lactamase, you will go for penicillin plus beta-lactamase inhibitor like Coamox. This also works against Staph aureus. Your cephalosporins have similar profile, with the key difference being that cephalosporins do not cover anaerobes, whereas the simple penicillins and penicillins with beta-lactamase inhibitors do. Carbapenems, another beta-lactam, do cover anaerobes, they do cover staph, they do cover strep, they do cover beta-lactamases, including extended spectrum beta-lactamases. Some of them cover Pseudomonas, some don't. So we will cover Pseudomonas in a second. You have your aminoglycosides, like gentamicin, which is the fave of gram-negative in ED, because you can give somebody a shot of gentamicin, oftentimes a single one, and they will be fine. Now, you have to be wary of them, as they can have a few certain side effects, including ototoxicity. I like my hearing. Now, this is rare, but you have to consider it, which is why you don't want to give it unless somebody is septic. You have your glycopeptides like vancomycin. These are your gram-positive wonders. They will treat anything in that area, but they are totally inactive against gram-negatives, which is benefit in C. diff infection and problem for a lot of other stuff. Then you have your tetracyclines and macrolides like doxycycline, clarithromycin. Work well for atypicals like Legionella or Chlamydia. They work for a bunch of gram-positives to some extent as well, but they don't really have much activity in gram-negatives. And then you have your ciproflox and moxiflox, your quinolones, which you would say they are the wonder drug because they cover pretty much everything. But the problem is it's very varied actually. There is a lot of resistance going around. And also they have especially ciproflox has a quite a nasty side effect profile, including things like, if I remember correctly, there were reports of suicidal ideation after taking ciproflox. Definitely Achilles tendon. So the tendonitis, it can cause your Achilles tendon to snap if you are unlucky. And a bunch of different stuff. It actually is a quite interesting nighttime read on the BNF if you'd like. And then you have your Metro, which is your specific anaerobe targeting antibiotic. We also use it in a bunch of parasitic infections as well. Special bugs. In Staph aureus, it's not here on the slide. I will add it before I send it out to you. You have your Fluclox, which is one of the penicillins, and the only penicillin which covers Staph aureus, and your first line for that bug. For MRSA, with its PB2A modification, vancomycin is effective. ESBLs, if you look through, Oh, we are losing people. Hopefully you can still hear me. We have our carbapenems, and then we have Pseudomonas with the five antibiotics. And that I do recommend you learn. You have your piptas, which is the only beta-lactamase combination that works against Pseudomonas. You have ceftazidime, but not ceftriaxone. You have meropenem, but not ertapenem. You have your gentamicin, which is why it's lovely, and your ciprofloxacin, which is the only oral option of this collection. So, not great. We have another Socrative. Okay, may I get some answers to that? Okay, I'm going to wait for a little bit longer, and hopefully I haven't put you all to sleep. Okay, let's have a quick look. All right. Now, that is not surprising, but there are a few different things which I would like you to consider with that question. We have our 60 year or you have 60-year-old man coming in essentially with confusion. He has dysuria, urinary frequency, and abdominal pain for the past few days. So people have correctly identified that we are talking about a UTI of some sort. Today he has woken up confused and agitated. In a 60-year-old, possible. We are talking about delirium, maybe. Now, I've given you those not without a reason. We have a fever, again, infection. We have blood pressure of 100 over 54. Mm, not super great. Heart rate of 115 and rest rate of 24. Now that is the triad I've mentioned earlier, which is the low blood pressure with so with our heart rate and high rest rate. So we have our hemodynamic instability. He is also confused and agitated. So what we are most likely talking about is the urosepsis. So the blood cultures is again something you would do first ideally, and do appreciate the confusion there, and I assume that's what you were meaning to. But in terms of highest priority next step, I maybe should have specified that if you were to do only one of those things, you want to give antibiotics within that golden hour. Blood cultures are less important than antibiotics, as the sepsis 6 will say. Do not delay antibiotics for the blood cultures. And why piptas, you will ask? Now, there is a history of colon cancer on chemotherapy. So you have to consider if you have a history of the patient being on chemo or having aplastic anemia or like CML or different leukemias, you have to consider that they are likely to be neutropenic. Neutropenic patient equals cover Pseudomonas, So you need to give them something that will cover Pseudomonas, which in this case will be Piptas. So very good thinking, questions with a few different levels, but essentially that's a quick reminder to always think sepsis, be on the lookout of is the patient neutropenic, and ask yourself, is the question asking about something you would do first, or is it the most important thing? Or if you were to do one thing, what would you do? Hopefully you won't hate me after this. So, sepsis. You have infection, it became systemic, malfunctioning damage of the body systems. Low blood pressure, high heart rate, high resp rate. You do your sepsis 6, which you will have done to death in the SGTs, and you do not delay antibiotics for cultures. If you can insert that catheter, or if you can insert that cannula and take the blood cultures, do it. That's ideally. If you are going to wait with the antibiotics for cultures, just give the antibiotics. Of note, if your patient is neutropenic, either clinically or biochemically, so if FBC says low neutrophils, or clinically, they are your cancer treatment patient, they have aplastic anemia, you do need to cover the Pseudomonas. So give things such as Piptas, gentamicin, or whatever of that 5. Lactate, you will get a VBG or ABG, and for urine output, you will typically drop in a catheter. Now, specific infections. Diarrhea and gastroenteritis. I think that people on this call have attended my GI lecture. I've been asked specifically to cover this again. May I hear from somebody whether we want to go through this again very quickly, or should we progress to the other stuff? Oh, I love the fact that we are getting less and less. Do the two people in the chat still want me to go on? If not, just disconnect. But here we go. So yeah, as we've discussed, there is the viral gastroenteritis, rotavirus, vaccine, kids in nurseries, norovirus, adults, wards with kids going out both sides, with vomit and the other thing going out both sides. The treatment for viral gastroenteritis primarily supportive. You have your food poisonings, so you have your preformed toxins. Now these you will recognize them in the question as your eating sassy food will happen 6 to 8 hours prior to ingestion, so very quick. So these are your Staph aureus in your reheated foods, your Bacillus cereus in rice, and Clostridium botulinum in your packaged foods. You have in vivo formed toxins. You have your Campylobacter from undercooked chicken. You have your cholera with rice water stools in poor sanitation conditions. Shigella, which will be your tropical and it will be bloody diarrhea. You have your Salmonella, which again will be maybe in different areas. You have your E. coli, and diagnosis is stool PCR with or without culture. You have if you have GI infection followed by neurosymptoms, you have to think, could this be Campylobacter? Could this be Guillain-Barré syndrome? Traveler's diarrhea, we may experience it at some point, any of us. You have your E. coli, which is the most common cause, which would be just watery diarrhea after drinking tap water in the Philippines or wherever else. You have your cholera, we've discussed it, and Shigella with diarrhea with blood and mucus. Entamoeba is a different. You get some diarrhea or diarrhea of blood, but then you get right upper quadrant pain. and that is your liver abscess. You can diagnose it with stool wet prep or serology, and that is one exception to the drain the abscess. You don't need to drain the abscess in Entamoeba histolytica infection. You just give metronidazole. Your giardia is another infection of the GI tract, which presents unspecifically, a bit like it's a mimic of the celiac disease, with the bloating, kind of unspecific diarrhea on and off, some nausea. It diagnosed with the stool wet prep, and treatment is metronidazole. Of note, you have your typhoid fever, caused by Salmonella typhi or paratyphi, and that is your Southeast Asia trip, and presents unusually to other infections with constipation, rash, fever, and abdominal pain. It usually self-resolves, but they need to be closely observed and potentially hospitalized, as there is a risk of perforation. And then things get bad. EHEC is a bit of a special case, as you have your petting zoos as kind of your typical prompt. You have diarrhea with blood, enterohemorrhagic, and hemolytic uremic syndrome. Hemolytic, so you get hemolytic anemia, you get thrombocytopenia, as linking to other strands, it's an example of MAHA, and you have kidney failure with your uremic syndrome. This one you treat primarily with supportive care. And C. diff is using too much antibiotics. You diagnose with ELISA or toxin PCR. And again, don't throw Coamox or Piptas at everything you see. There is a reason for that. C. diff is one of the big ones. Right. So, we covered a lot of that. I guess for C. diff, you have your 4 antibiotics you want to avoid. You have your Coamox, ciprofloxacin. We love it for so many things, as you can see. Clindamycin and ceftriaxone. Everything else we've pretty much covered earlier, but it will be on the slides. We have some Socratives. Again, we have 2 people left. So I'm going to wait for a second and we will go in. I may have used that in the GI tract lecture, so you may already know the answer. Okay. Again, not a bad guess, but let's go through. So you have 29-year-old man in the Green Mountains of Vermont. He drank water from the mountain streams, which is, you are thinking something that lives out in the wild. And then we have no abdominal marine on masses, afebrile, bowel sounds present. Seems relatively mild. Stool negative for occult blood, which is good. It abates in 3 weeks. 2 children similarly affected. What is the most likely cause? You can do it in kind of the elimination pattern. You have a rotavirus. You correctly identified it's not that. It's typically in children, not in 29-year-old men, and very young kids. It's your nursery kids that get it. Shigella flexneri, correctly identified it's not that. It does live in the wild, but typically in lower income countries of interest. Uh, and you would expect blood in stool, at least occult blood, if not frank blood. Now, Vibrio cholerae is a good guess, so it is a watery diarrhea, but the questions will typically mention low sanitation conditions, a high density of people, not wildlife, and also the stool is very characteristic. It is your rice water stool. And again, if you want to see the example, go on the stove, cook rice, remove the rice, the water left over is what's coming out of those people back end. Not nice. Now, Giardia is the only one it fits. It does live in the wild, in the freshwater in particular. It presents in this very non-specific way. So some mild diarrhea, that's watery. It abates in the 3 weeks and very much nothing else. It is infectious as well. So his kids, again, very well may have caught it from him. So again, it's essentially the only one that makes, that fits all of the criteria and doesn't miss out on anything. I hope that is a bit helpful. Question 4. That is the preparation for our next slides. So have a good go at it. But don't worry if you don't get it. Okay, let's have a look. Okay, again, very fair guess. And let's talk through everything. We have our 33-year-old female, coarse crackles in left lower lung field. You correctly identify that this is most likely community-acquired pneumonia. Now, I gave you a few hints as to why I'm requested the investigation I want you to do. Now, at this point, you know it's pneumonia. You know most likely it's strep pneumo. You could do bronchoalveolar lavage and PCR for the sake of completeness, but that's a bit of an overkill for a simple community-acquired pneumonia. But I did give you a nugget that I hope can make you think. Now, she's not a smoker, she's not a drinker, no significant past medical or surgical history. Now, the question that ID doctor will ask is, why the hell does she have community-acquired pneumonia? Just why? Now, patient said that she's surprised how she has gotten so ill. She firmly believes in traditional Chinese medicine. Regularly attends acupuncture with her herbal practice practitioner, who introduced her into complementary medicine. I gave you one risk factor as to the underlying condition. We see the pneumonia. What's hiding in the plain sight? And if there is one test that every ID doctor you will meet, you know how essentially any patient that comes into the hospital gets an ECG and chest X-ray. ID doctors would like to add HIV test into that good morning, how are you bundle. You have a risk factor for HIV in the form of acupuncture. If any of you are acupuncture fans, it actually bans you from donating blood for 4 months so that they can test you for HIV before you donate. So there you go. Always consider HIV, especially if you have a patient when it's like, why the hell have they developed this infection? So, HIV and AIDS. You will know it's a RNA virus, reverse transcriptase. Transmission is blood and sexual. And as I said, do not forget non-sterile procedures, which involve piercing of the skin. So tattoos, especially prison tattoos. No worries. Okay, Sion, let me know if you want to leave. We can just whiz through everything that we have. We might, I will have the questions on the slides if you don't want to do any more Socrates and we just whiz through the slides. How does that sound? I will send you the questions in the PowerPoint. Is that okay? Yep. All right. Again, the illness can initially be very silent. Yeah, I mentioned acupuncture in non-reliable places, especially if they try to sell you multiple different things at the same time, as this lady in the question before. High risk areas, anywhere is a risk area, but Southern and Sub-Saharan Africa, I know it's colonial term, but that's what's in literature, is a very high, it's a high risk area. It tends to be silent initially. You have to think about seroconversion illness, which is your bad flu-like illness with or without rash, which happens 1 to 3 weeks post some sort of risky behavior, such as unprotected sexual intercourse, doing IV drugs, or things like that. So do not think about every flu is an HIV infection, but if it's a flu after getting a prison tattoo, definitely do consider it. It tends to be silent, and as your CD4 T cell count drops, you can get indicator conditions. Here you have your classical things like your Kaposi sarcomas here, pneumocystis pneumonia, which was the first thing they characterized it of, cryptococcal meningitis from the slide with India ink. That's when your CD4 count is in the 8th territory. But reactivation of TB, as I've mentioned, community-acquired pneumonia with no other risk factors, shingles reactivation. These are your possibly HIV conditions where you should strongly consider HIV test, especially that they show up much earlier before the patients develop HIV. Diagnosis is you want to do a test, you will need verbal consent from the patient, and you treat with highly active antiretroviral therapy as soon as HIV is diagnosed. Don't wait for the CD4 count plus to drop. Undetectable equals untransmissible. So HIV positive person with undetectable viral load does not pass the virus on sexual intercourse or potentially on sharing needles or things like that. Not that I would do that, but for sexual intercourse it's actually quite relevant when you have couples when one of them has HIV, the other doesn't. And you can use the HAART or other the HIV drugs as pre-exposure prophylaxis. For example, people who are going to have unprotected sex and they know about it, or post-exposure prophylaxis, such as you, as a med student, you get a needle stick injury from your HIV patient. TB, infection which behaves like cancer, caused by Mycobacterium tuberculosis. Patient presents coughing up blood or coughing up sputum, fevers, chills, unintentional weight loss, night sweats, your symptoms of cancer. It can cause infection anywhere in the body. The lung is most common, but it can also cause TB meningitis, like you will see when they talk about CSF results for TB. It will be relevant for TB meningitis. Spinal TB, quite nasty, very painful condition. But name an organ, TB has gone there in the past. You have your high risk area, again, Southeast Asia, Africa, Western Pacific, especially if there are prolonged stays. But TB is present globally. Typically, the question will give you some of that, just to direct you towards TB. But in the real world, if you see those symptoms, TB Essentially, TB is always a differential to lung cancer, 100% of the time. Now, high-risk circumstances for TB and in particular reactivation of latent TB, immunodeficiency, in particular HIV positive, anti-TNF drug, like drugs for rheumatoid arthritis, like infliximab or for Crohn's disease, or if they are in prison, high risk of infection, or healthcare worker, in particular in those high risk areas. Every staff member coming into our trust does get an IGRA to check for latent TB. For histology, this is your TB histology slide. You get central necrosis, caseous or cheese-like necrosis, surrounded by epithelioid cells, which are the modified macrophages. You can get the giant cells, and you get a rim of CD4 plus positive T cells secreting TNF alpha. That's why anti-TNF agents or HIV increase the risk of TB reactivation. Now, you will start diagnosis with chest X-ray or CT lung. And the gold standard for TB is sputum culture, and they do like this question. It's not PCR. The most sensitive is sputum culture. It also gives you AMR profile. TB PCR is useful when you want diagnosis fast, such as TB meningitis, or if you get, and when you have latent TB, IGRA is your test of choice. It checks for T cell responses to TB, or tuberculin test, but it's older and not used much because it's non-specific. It will, for example, react with if somebody has been vaccinated against BCG. IGRA is specific to TB. Treatment, essentially you have 4 antibiotics. If it's resistant, it's above your pay grade. Even as a doctor, you call your ID and micro. Skipping Socrative. Herpes viruses. I will summarize things as you will cover that elsewhere. Herpes simplex is cold sores. It can be oral for 1 or genital for 2. You can diagnose it with the PCR of the vesicle fluid to confirm, and you treat it with acyclovir. Once you get it, it's permanent. You can treat the flares, but you aren't able to eradicate the virus. Of note, you need to remember HSV encephalitis. So your vignette will be older patient, potentially immunocompromised, but not necessarily, rapid deterioration of cognition, and strange behavior. MRI will show this enhancement of the medial temporal lobe, and the gold standard diagnostic is the PCR of their cerebrospinal fluid, specifically for HSV. You don't want to do multiplex panel, as those have only approximately 50% sensitivity for herpes simplex virus 1. So you want to do specific primers for HSV1. And you treat with aggressive acyclovir and hope for the best. You have your chickenpox, your varicella zoster. You have your macules to papules to vesicles. Essentially starts with a rash, which goes into blisters and is crossed over. In older age, this can reactivate, which typically goes like a band in a single dermatome, known as shingles. It is very painful. However, there is vaccine available, both for kids for the primary chickenpox and for adults who had chickenpox to boost their immunity to prevent from getting shingles. Epstein-Barr virus, these are atypical lymphocytes. It infects the B cells in the lymph nodes. In kids, it's asymptomatic, so give you mild flu-like illness. In teens and adults, it's mononucleosis, so kissing disease, very painful throat, and swelling of lymph nodes. If you do a blood film, and they do like this question, you get atypical lymphocytosis, so a lot of lymphocytes which are primarily T cells. So although infection is of B cells, in the blood you get T cells which are looking a bit dodgy. Now, the risks with EBV, it may cause cancer, so your Burkitt lymphoma with the Scaris type picture in here. It may cause nasopharyngeal carcinoma if you are in culture that likes smoking and salted fish. Burkitt lymphoma is association of EBV plus malaria, interestingly. So your typical infectious disease cancer. And finally, CMV. Why is it important? It typically infects children. As I said, both for EBV and CMV. Most of us have it. However, in immunocompromised, it can get reactivated, cause pneumonitis, so the lung infection, retinitis, infection of the eyes, and hepatitis. You can recognize it with those all eye inclusion in the infected cells. And another important note, more relevant in year 5, most of the herpes viruses, so herpes simplex, chickenpox, cytomegalovirus, can cause congenital syndromes if mom is infected for the first time in pregnancy. Spirochetes, as I said, they don't talk to you about much that in LabMed, but it's relevant because it is in the syllabus. Syphilis or Treponema pallidum, which is the bug that causes it. It is a STI, so the risk factor will be risky sex. It presents in 3 stages. Stage 1 is here. It's the painless ulcer on the area that got infected, known as the chancre. This heals by itself. Then the secondary syphilis, the flu-like illness, potentially with a rash. But again, it resolves on itself, so the patient thinks they are fine. And then tertiary syphilis, and then when it spreads and causes either unexplained neurology, known as neurosyphilis, or random granulomas across the body, known as the gamma. The diagnosis is a bit complicated, and I apologize for that. You have your non-treponemal test, which essentially tries to test are there live bacteria inside of the body that are syphilis. It will be positive only in active infection, but it is non-specific. For example, if you have SLE, it will also come up positive. And then you have treponemal test, which is an antibody test. So it is specific to syphilis, but if you had syphilis once, it will always be positive. So for that, if you get both positive, it is syphilis. If just VRDL is positive, it's a non-specific result. You may have SLE or other autoimmune condition. Just positive for EIA or treponemal test. You had syphilis in the past, but you don't have it now. Lyme disease is your outdoorsy person. They've been bitten by a tick. And characteristic is erythema migrans, so the bullseye rash. You get joint pain and flu-like symptoms, and you may wander around doctors for years. Of note, if you have a history of erythema migrans, that's your diagnosis done. You don't need confirmatory test, and that's one of the questions I've included in the Socrative, as you will see. If erythema migrans or the bullseye rash doesn't always occur, which is why you would test for antibodies if you have a history that matches this profile, but does not have reported bullseye rash. Finally, leptospirosis. It's your returning traveler or somebody who works in the sewers, farmer or a vet, also known as exposure to rat urine. Characteristically, you get deranged LFTs and deranged U's and E's together. Both of them are being hit by the same time. You confirm the diagnosis by ELISA. And those are the spirochetes, which are the bacteria that form this characteristic spiral pattern. And heading towards the end, febrile returning traveler, we have the malaria. caused by Plasmodium parasite, carried by Anopheles mosquitoes, characteristic, recurrent fevers, and travel to Africa, Southeast Asia, Central America. They may be jaundice due to hemolysis. If the question says that they did use malaria prophylaxis, they want to say to you, it is not malaria. If they didn't use malaria prophylaxis, or they don't mention it, you will consider malaria. Gold standard is the thick and thin blood films with game sustain, like here. But there is also rapid diagnostic test. If the question asks you, what is the fastest way to test for malaria? It's your rapid diagnostic test, which is essentially a lateral flow test. Dengue, it's a virus carried by Aedes mosquitoes. What I find helpful are the two characteristic bits. The breakbone fever, so they are very painful, achy muscles, very like the pain in the bones, as the name suggests, and in the joints in particular, or retroorbital headache. So the question will talk about this weird headache that it's just behind my eyes, doctor. So that tells you this is dengue. And again, with diagnosis, it's antibodies for gold standard, but the full blood count supports you as they will have low white blood cells, low platelets, and high hematocrit. We've talked about typhoid, so I'm not going to repeat myself. And viral hemorrhagic fevers like Ebola or Marburg fever. You travel to endemic area, they are fever, they are unwell, and later on they bleed from everywhere. MERS is your respiratory symptoms. However, here the question will be more specific. They have just traveled to Arabic Peninsula and they were riding camels. Again, we will miss the Socrates, but the key thing about your questions about tropical medicine is incubation periods. Those questions will typically tell you that they've been somewhere, they've returned like 10 days ago, and let's say they've returned 2 months ago, and since 4 days they are having fevers. This allows to tell you, okay, they returned 25 days post-return that they had their first symptoms. And what do incubation periods tell you? If it was dengue, they would have gotten their symptoms maximum 2 weeks after the last possible exposure. If it's 25 days post-return, it's not dengue. You cross it out your list. Same with MERS, 2 weeks. Ebola, maybe 3 weeks after they have gotten back, but it's 25 days now. It's not Ebola. Now, typhoid, it can be activated up to 30 days post-exposure, so it very well may be typhoid. And finally, with malaria, it's the one exception where it kind of doesn't apply, or rather, I would say, although it says kind of 180 plus days, I would say if it's within a year after coming back from their travel, it can still be malaria. So I guess that's kind of the key for the tropical medicine. And the side note, you will be thinking about electives at some point, so I highly recommend the NAFNAC website just to think about the possible risks. And if they have not been using the malaria prophylaxis, check whether they are at risk. And for other stuff as well. Of note, what you will see in real life is that it's not usually tourists who get malaria, or sometimes they do, but oftentimes people who, for example, or were born in, let's say Sudan, for this example. They were born in Sudan, they have immigrated to the UK, they lived several years in the UK, and now they came back to visit their family, and they didn't think they need malaria prophylaxis. They come back to the UK, and they start to develop the fevers. Malaria immunity does wane with time, And oftentimes your patient that will present is somebody that's originally from high malaria region and they visited their family, didn't think about malaria prophylaxis. So thank you so much, Sion. Hopefully I pronounced your name right. Feel free to fill out the feedback questionnaire. You will get the slides. Uh, and yes, if you have any questions at this point in time, we still have a few minutes. I'm happy to answer anything you may have about ID, micro, whatever you like. So yeah, I'm going to just let you scan this. Uh, Lovely. I assume that you have scanned the QR code, so I'm going to stop sharing. Yep. Thanks everyone.